Recently, a woman that we were consulted on in her 40s went to the emergency room with a headache. And the emergency room doctor did a thorough and complete workup for the patient and found that she had a cerebral aneurysm in her head. I talked to the emergency room doctor, and after reviewing the CT scan and the CT angiogram and her symptoms, concluded that the aneurysm was probably not the source of her current complaint. However, it was something that we would be happy to talk to her about. What should you know about an incidental cerebral aneurysm? In other words, what if you or a loved one are found to have an aneurysm that hasn't bled? What are some of the things that you should know about that situation? From population data, we know that about 3% or so of patients across the board have an aneurysm in their head. Most of these patients don't even know that they do. But if you do diagnostic imaging studies for all kinds of reasons, you will find cerebral aneurysms. It's also known that about 6 patients out of 100,000 per year suffer a ruptured cerebral aneurysm. So the risk of an aneurysm rupturing in the population data is much less than 1% per year. On the other hand, if a patient suffers a rupture, the risk of them dying from it is high, probably as high as 35% or more. Also, if the aneurysm ruptures and they survive, the chances of having disability are high. So basically, we're dealing with a problem that has a low risk of occurring, but has a high consequence if it does occur. What are some of the things that we should know, or you should know, that increases the risk of an aneurysm rupturing? So there's some genetic predisposition. If a family member or 2 or more have had a subarachnoid hemorrhage, then the risk of rupturing is higher. If a patient is of Finnish origin or Japanese origin or certain other ethnicities, the risk is a little bit higher. There are certain modifiable risk factors such as hypertension and heavy alcohol use and smoking that increase the risk of rupture. Certain genetic conditions like polycystic kidney disease have an associated risk of subarachnoid hemorrhage and aneurysm formation. So these are some of the things that we would want to know in counseling and getting a history from a patient. On the imaging studies, we will be looking for certain characteristics, such as the aneurysm's location, its size, its morphology or shape, if it's changed from year to year in terms of its size and morphology. And there are some scales that can be attributed based on that information. I would say that it's good to sit down with somebody and have a discussion about the aneurysm and its risk of rupture, and then to also have a conversation about what possible interventions could be done to secure the aneurysm, such as clipping, which is a surgical procedure done with a craniotomy, or coiling, which is an interventional procedure done through a catheter placed in the artery. One final comment is the decision-making process for either watching an aneurysm over time or deciding to intervene is a complicated one, and it involves a lot of information and expertise. And so it's wise to be connected with a multidisciplinary team that deals with aneurysms on a regular basis.